Welcome back to OTW POD. I'm TJ Halverson, and today we're going to dive into a story about collaboration and what happens when we bring the best minds in medicine to help work together to improving patient care. And our guest today is Dr. Timothy Deere. Welcome to the show.
Well, TJ, thanks for having me. It's great to be here and on your format, which I think is always intriguing, and I'm honored to be here today.
Yeah, no, I really appreciate you taking time out of what sounded like a very busy morning. I want to start off with this first question because our audience has been the orthopedic surgeon in that community. And you've been at the forefront of pain management for over 30 years. And you've watched this field evolve tremendously. So if you would, take us back to when you started. What did that landscape look like then? And where is the resistance to progress coming from today?
Well, I think the resistance today versus then is very, very interesting to compare. When I
Yeah.
came out at the University of Virginia, where I did my fellowship in the early 90s, basically it was the same time that things like OxyContin was getting released, to the communities of Appalachia and nationwide. I think,
Mm-hmm.
we that happened, and then pain physicians were also mostly anesthesiologists, so they would do anesthesia, and then 1 or 2 days a week do injections, and then the only other option was either medication injection, an ablation, which was pretty new back then, or fusion or large surgery. So
Mm-hmm.
really the number of options for the patient as you go down the treatment path were pretty low. So we would
Mm-hmm.
do a couple of epidurals, send them over to the ortho spine surgeon, they do a fusion, send it back to us, we do a stimulator. It was kind of that way,
Right.
if anything worked along the way, you stopped. The other
Mm-hmm.
thing we were all trying to do together was get people off opioids or avoid those of us who were minded that way. So the resistance back then was there, and there were some
Mm-hmm.
surgeons who didn't want us to do a permanent stimulator. The neurosurgeons in some communities, and we taught our colleagues to do permanent stimulation at that point, so we taught them
Yeah.
how to do that. Was the first step into surgery, was permanent spinal cord stimulation when I came out. That's really the first point of resistance we ever had to what we do. And the way I got by that was my neurosurgeons and I became good friends, and we decided, simulation was my area of expertise more than theirs, and I did most of the
Mm-hmm.
devices. But that was a collaborative discussion.
Right.
Uh, a
Right.
big right.
Mm-hmm. Yeah. And I've heard you talk about having an algorithmic approach to your patient care pathway in your clinic. And it sounds like that was, developed and discovered really over 30 years of practice and having those conversations with your colleagues on the ortho or the neuro side. How did you develop that algorithm? And what does that look like today when a patient walks into your clinic?
Yeah, it's changed dramatically. So in those days, everyone got, and so your orthopedic spine surgeons who listen to this podcast will remember these days, everyone got 3 epidurals. It's just the way it happened. And then you got some PT, you might get some medication, and then you either got surgery or you didn't. And many times you
Mm-hmm.
got disc replacement surgery in those who had back pain for black disc. So the treatment algorithm was there, but it was very small. It
Mm-hmm.
wasn't well thought out. It wasn't evidence based. So it was
Yeah.
probably a pretty bad treatment algorithm, but it was the best we had. Now, if you look at 2025 and going forward, there's still the same thought process, but there's a couple of big differences. One is, I think we're much better at making the diagnoses of the pain generator as a group. Ortho, spine, visual pain, neurosurgery, we're all better at that diagnosis process. Two is, I think we have a lot more things along the path to offer. And so we don't start with a big fusion. We don't start with, an opioid. We really start where the patient comes in. And if
Mm-hmm.
they have 3 or 4 things that are indicated based on the imaging, and
Mm-hmm.
then we have to pick which one of those to do first. And so that's really the answer to the question. When I see someone with BVN, whether it be a candidate for BVN, they be a candidate for some form of, minimally invasive spine procedure, I
Mm-hmm.
ask, what is the most functional limiting thing you have going on? You know, so that's what drives the first step in that algorithmic treatment today is
Oh,
functional limitation. Is there anything either I or my surgical colleagues can do to improve the functional limitation?
mm. Got it. Now, in terms of the diagnostic approach, we can celebrate all the advancements that we've had there. I've heard you talk about some new advancements in that diagnostic, even with, um, correct me if I'm wrong, but I heard you say something about, was it urinalysis that's you're doing some research on, and looking for ways that you can apply better diagnostic skill sets and data sets to these patients that are coming in. But I've also heard that, many people will say it really depends on where you start. So if you start with an orthopedic surgeon, you're more likely to get a surgery. If you start with a pain doc, you're less likely. I mean, I believe that there's probably some credence to that, and I don't want to paint anyone as a good or bad physician as a result of that. But you know, is that just from history? Is that from the data coming out? Is that just based on bell curve of a physician in how they you know measure out what this patient should have happen, right? Their treatment pathway.
So, TJ, you bring up a lot of points. So I'm going to break them into
Yeah,
into
let's break
categories.
it down. Yeah,
It was a long question. So first you mentioned biomarkers. We'll talk about that first. Then you mentioned, where are you going to go with based on who you see first, and then the third
yeah.
thing, you mentioned the bell curve of physicians. So I want to address all three of those, and we can
Let's
go
do
back.
that.
So the biomarker thing that you mentioned, there's many of you may know, listen to this podcast, there's some blood work now you can have done where it looks for every cancer marker in your body. They can tell you if you have a cancer going on. And I know some people who've been diagnosed with pancreatic cancer who had no symptoms very early because of that blood test. And I'm going to get that blood test in the next few weeks because I wanted to see what that
Yeah,
showed. But so that's where we could go eventually with the spine. There's urinary pain markers. And that really shows not what's causing the pain, but potentially that could show your response. And are you optimized on
right.
nutrition supplements? Are you optimized to have a good neural response to whatever any of us does? The biomarkers currently are imaging based. So we have modic
Correct.
changes for MRI for BVM. We have ligaments and flavin thickening for mild procedure on MRI. So there's things right now that are out there for things like Bivex. We have Furman scale for the disc. So we know there's
Hmm.
biomarkers and imaging that correlates well to a good outcome. So that's where we're going now. Is right now with the spine will be in the
Yeah.
imaging predictors, but eventually maybe better than that. But
Hmm.
I kind of disagree with the doctor you see first is what you get. And I think that was true in the past. If you have anybody that listens to this who's a pain doctor who really just doesn't want to send a patient to the surgeon, he or she may go down the path of all these things that maybe some of which are inappropriate, and they may not get to the surgeon until very late. If
Right.
you see a surgeon who's really knife happy, they may operate on someone right away. But I think those are outliers. Those are the people who fight on LinkedIn with each other, right?
I
Those are
agree
people
with that.
you don't want
Yeah.
to see either one of those people because they're both bad. But if you see surgeons I work with are very, very, very real well trained, and they're very selective. They'd rather me
Hmm.
see the patient first many times because they may have to go through 100 patients to find one appropriate surgical candidate. You
Right.
know, and likewise, if I see a patient on day one and I look at the X-ray and they have grade 2 unstable spondylolisthesis, I'm sending them right to see the surgeon. There's nothing I do that's appropriate in that patient. Do you think that changing, going back to that question, I think it's changing. That's why I said the bell curve I don't really agree with, because really a
Yeah.
bell curve looks like this, right? I think what we see
Right.
in all of our fields are you get better and better and better and better periods. And then there's some point where you start to go downhill and deteriorate. It's kind of a
Mm,
slanted bell curve. And the majority of
right.
doctors that we're going to see trained in the future are going to be more to the right of the bell curve on the top. And I think that in the right
Yeah.
now, the two sides will go away because no one wants to deal with those people because they're doing a bad job for patient care.
Hmm. Yeah. No, I think that's very well put. Very, very well put. When you were identifying the docs that you work with on the orthopedic surgeon side, how did you establish that methodology of valuing? All right, is this a doc that we either agree in our approaches and we want to have this relationship back and forth? Was it, hey, I've seen his work and it's well done? How should other interventionalists evaluate the potential partners on the orthopedic surgeon side and vice versa?
Well, I think the insurance companies has helped us with some of the orthopedic surgeons we wouldn't want to work
Yeah.
with. Because,
Yeah.
some of the folks we used to see that were very, very aggressive, most of the time now, like large fusion for axial back pain with no leg pain, and those being usually not approved. So I think
Yeah.
really that the patient selection has been driven almost obviously too far by insurers, where sometimes
Mhm.
people that would have been operated on. But what I find to be helpful is a personal discussion. So when you have that personal discussion and we hear each other's philosophies, I think when we're like-minded, and what we mean by that is we think we want the best thing for the patient. But the other thing that we've done really well, if someone comes to sees a surgeon who has COPD and heart disease and is 80 years old, and they may benefit from a larger surgery, but I could do a posterior lateral arthrodesis at L3, 4, L4, 5 for a
Right.
great spondy. My surgeon's gonna probably, at this point, refer that person to me because they don't wanna put them through the larger surgery. Same with mild, the same with, BVN, the same with so they're gonna send that patient to me most of the time. Whereas if
Mhm.
I get someone who has critical cervical stenosis, I'm gonna immediately call my surgeon when I do found hyperreflexia and, all those things
Right.
that I look for. So I think really that we really just have these discussions, and what we find is we've come to a common ground. So I don't think
Yeah.
it's really so much what surgeon to pick or what interventional doctor to pick. It's who's a good doctor. If you meet people that you think that's
Mhm.
a good doctor, what's going to happen is we're going to just over time come together in that discussion and those decision making. And I really found it to be very
Right.
easy. I'm surrounded by good doctors in 3 or 4
Yeah.
towns around me. And we've really had nothing but good interactions. And the bad people that have came and gone, they've came and gone. I don't know where they are
Right.
now. Maybe they're
Yeah.
all in Texas, but they're not here. That's for sure. Maybe they're down in the coast of the Jacksonville coast of Florida or somewhere, but they're
Right.
not here. So I think that good doctors will come together in these algorithmic decisions and come to the right decision most of the time.
Yeah. Yeah. No, that's a great point. They come and they go. Now, I also have to wonder, there's a lot more patient education today. How have you seen some of the patient interaction or the patient demand change over the past 5, 10, 15 years?
Well, I really think it's been the last 5 years. And I'll tell you why I say that.
Okay.
Before 2020, patients would come see me and I'd say, we could do this, or this. And many times they would say, doc, I just want to be fixed. Send me to,
Yeah.
whoever, and I want a 3-level fusion. I just want to be fixed. And that was very common,
Mm,
and then many times, they do well. And then half the time they come back for a spinal cord stimulator trial by me. So, we saw good and the bad out of that relationship. When 2020 came along and COVID came along, I found 2 things happen over the next year. One is no one wanted to be in the hospital for a big surgery. No one.
mhm.
2 is, I think it's chat groups on Facebook and social media. No one wanted spine surgery anymore. I mean, the number of people who wanted a spine surgery in our experience went way down. So people would come to see us who'd already seen the surgeon. The surgeon had
Mhm.
recommended a surgery, and the patient would say, I'm not going to have that done no matter what.
Yeah.
And
Yeah.
so then the question for us was, is there anything we can do that's appropriate in that patient? Many times there is something we can do that's appropriate. And we would say, well, if it doesn't work, you're going to still end up having the bigger surgery. And they'll say, I don't
Mhm.
care. I'm not going to ever have it. And guess what? Most of the time they don't ever have the bigger surgery. But that really
Yeah.
changed the last 5 years. And I think it's the
Mm,
2 things that happened that desire to get out of the hospital, desire to have nothing big and risky, and then everything we're doing, we started to build data and evidence for, and we started
mhm.
publication of things like SI fusion and BVN
Mhm.
and mild. We started publishing data that was supportive, and insurance companies said, "Oh, that's pretty good data," and they started approving the things we do. So it's all these things coming together that's led to that shift. That's
Right.
why you see spending really shifting towards minimally invasive spine and interventional pain away from large spine surgery.
I want to get into this parallel. You are a multi Ironman finisher. You've finished the Badwater 135, which is one of the most brutal ultra marathons in the world. And you've approached what a lot of people see as just this impossible challenge, and you've gone and accomplished it through a physical feat. But there are also a lot of people who think that this synergy and this collaboration between pain, orthopedic surgeons, neurosurgeons, it's just not going to happen. There was a parallel that you drew before we started about the origins of Ironman and how we could, draw some parallels to what's happening today in medical devices.
So, we were talking a little bit about, our relationship, and I became friends with a lot of neurosurgeons and ortho spine surgeons nationally. And we talked about how that, if I've ever seen this experience before. And I went back to the beginning of the Ironman triathlon, and it was
Mhm.
at Honolulu, and John Collins was a naval officer there, and he and a Marine and a couple guys in the Army were all together one night in a bar, and the one guy was a great runner, and he said, runners are the best athletes. We're better than you. You make them ride a bike.
R
And then one
Right.
of the guys was a biker, and he's like, "Man, you guys, you can only run 26 miles. We can bike up." They were doing this thing called the 100-mile Hawaii bike ride. Then became 100, man. And then another guy they have a rough water swim in Maui. And one of the Marines was a great swimmer. And he said, no, the swimmers are the ones that are the best of all. And they all
Right.
really felt the best, right? They thought they were the best athletes. And so John Collins, I guess, as a beer flowed, he said, I'll tell you what, next Saturday, we're all going to meet down at Waikiki Harbor, and we're going to swim the rough water swim distance, which was 2 miles. It became 2.4 later with Ironman. And then we're going to jump on our bike. We're going to ride around the island, which was 112 miles. That's where that came in. And then we're going to run the Honolulu Marathon course. And whoever
Wow.
wins, we'll call him, and there's no women in the first race, but we'll call him an Ironman, and he'll be the Ironman. And he created a little trophy out of metal and a
Yeah.
T. And so about 15 people showed up that next weekend. And guess what? The person who won wasn't the best swimmer, and it wasn't the best biker, and it wasn't the best runner. It was a person who could do all three sports pretty well. He's and so it wasn't like you couldn't be like, "I'm the best at this," and not understand the other 2 things, and I think that's a correlation, right? We're gonna have to understand that season selection, procedural skills, and postoperative complications and management. So there's a lot of things there that are correlated, because if you're just really good at doing a big surgery, if you pick patients incorrectly or you can't follow them well, you won't have a good outcome. So I think we're in that phase right now where if you're really good at one thing and you think you're the best, you're probably misled because you're not balanced where you need to be balanced. And that's what we
Mm.
want to get to, balance.
Yeah. I love that. Thanks for sharing that, and, I think that there are ways that you're finding additional balance too through Aspen and continued education in some of these new certification programs. Would you walk us through and maybe provide a bit of an update on, how was this year at Aspen? What are you guys expecting in the future? How is that evolving? And ultimately, how are you continuing to empower the surgeons that are coming to Aspen to ultimately provide better care?
Yeah, so just for those listening, American Society of Pain and Neuroscience has been around 8 years now. I was president of several societies and worked in several on the boards, and I found a lot of infighting, a lot of, us versus them, particularly against the surgeons. Most of the pain didn't want to have anything to do with surgeons. They didn't want any diversity, and they didn't really want to mentor young people as much as I did. And that's not
Mhm.
globally true for all, but there was a big problem there. So myself and Dahlwood said, noticed the need. We created this society, and then one of our first goals was get more young people involved. And this year in Miami, we had over 1,500 young people, 5 years or less out of training or in training. We had, the
Yeah.
other 1,500 people after over 5 years, and quite a few other people. But we also wanted to reach out to the surgical community because we feel it's important that we discuss these issues as they evolve and collaborate together to make things better. So good examples, Angel Boab, a neurosurgeon up in Rochester, involved in a lot of our discussions early on about what we should do to certify pain physicians, because what happens is people go out of their fellowship, whether you be a surgeon or a pain specialist, you leave your fellowship or your residency, and guess what happens? New things get invented. So
Mm.
you may think in the world or the best interventionalists in the world, but there needs to be a process where when new things come along, you do them well. And so what's happened in the past, we've had industry train you for one weekend, pat you on
Mhm.
the back and say, go out and do this procedure, and so
Right.
that's not always optimal. So what I used to recommend was you have someone come in and mentor you on your first some few procedures to make sure you understood what you were doing. But I don't think that's ideal either. And so
Mm.
what we've led to now, Dave Dickerson from Chicago is the chairman of this project. David
Mhm.
Lee from out in California, Angel Boab. We got several people working on this. Ashley Bailey Clausen from Texas. So we have physiatry, we have interventional radiology, and Doug Beal and others. So what's been people applying that just started this year, the first class. We've already have international applications as well. They're going to pick 3 minimally invasive areas of interest that they're already able to get privileges to do. So they went to that course on the
Okay.
weekend, went to
Mhm.
So
Mhm.
let's say it's endoscopic discectomy, or let's say it's, the mild procedure or BVN. And then what they're going to do, they're going to have a mentor who's a person more experienced than them, not necessarily older, but definitely more experienced. And they're going to have things like case review, MRI review before they go to the OR. They're going to go
Mm.
to their case and have post case review. And that'll all be part of the program. They'll have didactic lectures every month from a mentor along the program. And then they'll come to Miami in July and have a hands-on cadaver-based certification led by Dr. Mehta from Texas. And they'll have a written exam that follows very closely the ACGME process led by Dr. Silver from Rush. So we created this to address several of those people who say, well, these people aren't well trained. We're going to try to up the training level to improve patient safety and efficacy
Yeah.
nationwide, but now that we're seeing the international applications, I think it may lead to worldwide improvement in MIS care.
Wow. Wow, that's incredible. It's incredible. We'll make sure to link how to learn more about that in our show notes below because that's something that's needed. There are people who are discussing going to 2 years. And why would you go to 2 years? If you spend a year in one place and you gain skills in one specific area, but you don't gain it in the new areas of technology advancements, then what's the purpose in spending another year?
Yeah,
Right.
it's funny you mentioned that because I was having I call it a friendly debate, but some of the pain people, they're really a little bit. They just want to go straight to a device or straight to an opioid. They don't want to
Mm,
do all these other things. And we were having this discussion, and one of those fellowship directors I was with in Chile this past week was like, "Well, we need to have a 2-year fellowship, not do all this type of training for procedural
mm,
things." And I say because they said, "Well, we need better, training on selection and behavioral therapies and all those things." But if your fellowship isn't very good in year one, guess what? 2 years of
mhm.
the same bad fellowship won't make you any better. So I think
Right.
no one wants a 2-year fellowship. The fellows don't want a 2-year fellowship.
Mm,
So I think that's not the way to go. And I think procedures
yeah.
are the way to go, whether you're a surgeon or interventionalist. The secret though is proper selection and proper training. So I do think
Mm,
interventional therapies are the answer for most spinal disorders, but only in the right patient at the right time with the right person who's well trained. That's what this
mm,
whole about. Who's that person, right?
yeah. Yeah. So what happens to those fellows if they go through this program and then they don't pass?
Yeah, so it's funny, it's an evolving process, we have to address that, but that
Hmm.
will be a possibility. There's some certification programs where everyone passes, right? It's like, you play soccer and you get a trophy, and the winners get the same trophy as the people who came in last, and that's been a
Yeah.
mentality that I've always hated. I want the winner to get the
Yeah.
winner's trophy, right?
Absolutely.
No, I think if they aren't competent, I've encouraged our mentors to fail them. I
Mm,
haven't decided if they can reapply or not. I would think probably not, though. If you don't have that
yeah.
skill set, maybe it's not right for you. Remember, certification is not same as credentialing. So you can get a
Correct.
certification, you may use that to help yourself go through a credentialing process. But what all it means is, and I think it's important for many people as far as insurance goes in the future, you've proven that you've done the work to go through a process where you pass a written and practical examination, much like we do when we
Mhm.
take our boards, so but since the boards don't cover most of these procedures, it's the next step up, where you prove
Yeah.
you're continuing to evolve. And, I think that's going to be very, very important. And we have this great
Mhm.
cadaver lab every year at Aspen anyway, and ASPN, which will be in London next month. We have cadaver labs there as well, where we teach people these procedures that they may have
Mm,
already had some exposure to through industry, but this
mm.
is just above that. This takes it to the next level up.
Right. Now, in response to what you guys are building, do you think that there are going to be more teaching institutions in the future that bring on those expanded education opportunities for interventionalists, for pain docs, or are they just going to continue to focus on the injections and other things that they have historically? Or do you think that will evolve too?
Well, that's a hard question, TJ. That's a really hard question there. Short truth is
Look into the mirror, look into the future, your glass
no,
ball, right? Don't you have that?
yeah, I've looked at it. There's AC. So let's go through this. And this is
Yeah.
a controversial topic that might ruffle a few feathers here and there. There's ACGME accredited fellowships, some of which are very, very good.
Hmm.
And I know 3 or 4 that they do everything I do in private practice. They do it very well and they treat your fellows. I know 3 or 4 programs like that. There's not
Yeah.
many, right? And usually
Right.
it's one of the few things. Either the program director doesn't know how to do these procedures, him or herself, so they can't
Hmm.
teach them because they don't know how to do them, or there's political pressure at the institution to offer bigger surgeries only. And so everybody gets bigger surgery. And so I think in those institutions, there's leadership needed, whether it be from the interventional spine pain person or the surgeon. Someone has to be the leader there to come in and help that and let politics fall to the wayside. But there's also non-ACGME accredited fellowships. And most of those are done in private settings where there is no political battle because there's usually only one specialty or two specialties. I think in those settings, people will get the exposure they need. And I think there's a risk
Right.
to ACGME fellowships that non-ACGME fellowships may get better down the road than the
Mhm.
ACGME fellowship, which would be unfortunate, I think. So they're going to have to step up the game. And I think that the non-certified fellowships are actually getting people, through the credentialing process in many, many surgery centers nationwide. And I think you might see a real shift away from certified fellowships into the non-certified fellowship realm.
Yeah.
And again, is that good or bad? I'm not going to be the judge of that, but it's
Right.
different, right? It's different.
It is. It is. And I think there's always the thought that if you aren't continuing to evolve with the new technologies, with the way of the future, then you're going to die. And that's a real harsh reality and something that most people don't want to talk about in our space because there are these phenomenal institutions that have been around for many, many years. But if we don't continually look to improve and ultimately improve the fellowship programs and the ways in which we help physicians take care of patients, right? If we're just going to boil it down to the simplistic form, we just want to help you be the best doc that you can so that you can help change people's lives. If you can't continue to improve over time, then that's a hard conversation to have. And I understand why it would ruffle feathers, but now that we're already kind of ruffling those feathers, let's talk about some of the, let's call it maybe the skeptics, right? People who are going, look, you can't let these interventionalists into orthopedics. They can't do MIS procedures. Let's talk about that, and let's just get a few takes. Right? We've already broached that in a few areas, but I'm just curious. Do you think that you know an interventional spine surgeon should be able to do a fusion? Where's the line? Help me understand a couple of these. Maybe the algorithm that you're working through right now, and where you think some of those lines are.
Oh, yeah, 100%. We have many people who do a fantastic job with either posterior lateral arthrodesis or a direct posterior procedure at L5S1. And, that's done every day in the United States right now. It's done in my practice. It's done in
Yeah.
several practices with good outcomes. And, we follow those outcomes very carefully. I think the big thing here is that, we actually have seen a change in patient flow. So
Mm,
if you're an orthopedic surgeon right now, the thing you need to think about, we used to depend on surgeons to refer patients to us. So at one point,
mhm,
90% of the referrals that most pain practices got were from a surgeon, and they depended on the surgeon's referral source. But what
mhm,
happened is patients started going back to the family doctor and say, I don't want to see a surgeon. I don't want to have a big surgery. And guess what?
mhm,
Now most referrals are coming from primary care way before they've ever seen a surgeon. So I think
mhm,
that the real, if it was a vote and it was a general election, the
sure.
vote is going our way dramatically. That's why you're seeing the
Mm,
shift. So
mhm,
if you patient, they're going to have a large fusion of the SI joint or a smaller fusion of the SI joint. They've already seen the pain physician. The pain physician offers the procedure. Guess what? They're going to have the pain physician do the procedure. Okay, and so
mm,
that's just the way
mhm,
it's going to go. And so I do think that then what we have as a responsibility is to make sure as we evolve that we really, really focus on patient selection. And there's many
mhm,
people who are inappropriate for the current technologies of MIS that
mhm,
whether you're a spine surgeon or you're an interventional spine professional, there's many, many people who just aren't appropriate. They need a larger
mhm,
surgery. And that person needs to see someone who can do a larger surgery, and that's the
mhm,
ortho surgeon or neurosurgeon. Now, here's what's gonna be the other kicker of that.
yeah,
More and more technology is coming, and I'm working on many disc projects right now for the disc example, and those are all done percutaneously. And those are all
right.
done under fluoroscopy, and those are all done by people like myself who can do that procedure in a few minutes sometimes versus 2 or 3 hours if you're not used to doing that type of work. So I
Mhm,
do think we may see, and TJ, I hate to say it, but we may see even
yeah,
more things that are currently treated with large surgeries go into our scope of practice where it becomes more to do. So I think many spine surgeons are gonna come our direction and do more and more minimally invasive things.
Yeah.
and we're going their direction, and we're gonna meet in the middle. But there's still
Mhm.
gonna be people that really should always see the spine surgeon because they have something that's really critical that needs a bigger surgery. There's people who should never see the spine surgeon because they don't need that procedure because their
Right.
problem isn't bad.
Well, 100%. And I think this is a good add-on to that comment. I was speaking to a friend who's been in the space for 35 plus years just last week, and he's led a lot of investment and M&A in the space. And he was at Aspen this summer. And he said, it was my first time ever there. And I saw all of the business development guys from the big companies also there. And it was all of our first time that we had ever gone to a pain conference because it's there. And we see this world converging. So I think that's additional validation that what you just said is true, that there's this meeting in the middle. So continuing on with that, there are these disc technologies. So if fusion isn't the line, right, is it disc replacement? Or do you think that we're going to move away from disc replacement in the future and we're going to have earlier stage minimally invasive technologies that we can do through fluoro?
I'm gonna answer that question first, and I'm gonna come back to the investors at Aspen and talk about that a little
Yeah.
bit because it's important. So right now, we're leading along with Pierce Nunley, a great ortho spine surgeon now. We're leading a study right now called Vivex for human, pulsus allograft. 450 patients nationwide. The study's just beginning. Level 1 RCT, sham controlled. And we're also, that's going to be a really important study. I think there's a similar study in Australia going on. If we have those two big RCTs, they both show great outcomes. You're going to see more and more insurers reimburse that very early on. We also, at the same time, are working on a project with Mesoblast, which is a stem cell company looking at stem
Hmm.
cells for
Hmm.
disc. At the same time, there's 3 or 4 other projects I'm working on that are more mechanical replacements of discs
Okay.
that I can't
Yeah.
talk today because confidentiality. There's also interdistal
Yeah.
stimulation projects going on.
Hmm.
I haven't decided to work with yet, but I may.
Yeah.
And so all those things are meant to replace current surgeries. Every one of those
Hmm.
things. And they're all funded for large studies. So if you have a large RCT and you have 2 of those, that usually leads to funding. That usually leads to reimbursement, CMS and rucking, right? So
Hmm.
that's why I'm pretty optimistic we're gonna go more and more less invasive in the disc space. No
Yeah.
question
Yeah.
about it. And, going back to the investment, that brings up the investment thing because
Yeah.
we have embraced industry in a very transparent and collaborative and way that's very compliant with all federal regulations. As we do
Hmm.
that, we've attracted more industry to Aspen and more investors to Aspen because we're attracting the early adapters for therapies. That means they want to do the study, and we're also attracting trained. And we're also attracting surgeons who are like-minded,
Right.
and our number of surgeons are growing like that. So I think that those 2 questions you asked, the disc question and the investment question, they kinda
Hmm.
and if you look at the money spent in
Absolutely.
spine versus specialists, interventional spine's doing that, and large spine surgery
Hmm.
doing this.
Yeah. We're already starting to see that. You've been in the room where both sides are hashing it out. How has that changed? And how are you helping the skeptics change their mind?
Well, listen, there's some people that you see on LinkedIn making stupid comments all the time about all kind of things. And it's just the anti-industry, like the industry funds a research project. Oh, it's industry, and you may have
Hmm.
five of your best ortho spine surgeons doing a project for a big. Let's say it's a big company like Stryker, and they're doing a big
Right.
project. And the data comes out great, and the first thing you're going to hear from the skeptics, oh, they're consultants for the Stryker. Well, that's why you have IDEs with FDA checks and things of that.
Hmm. Hmm.
So those people, I don't think I can help, TJ, just so you know. So I don't think I
Yeah.
can ever help that skeptic. I want that skeptic just to stay on their own little island and kind of go away. No one respects them anyway. You also have people that, want to control everything. Like they want to be in control. You shouldn't do this procedure in my surgery center. Well, that's not how credentialing works. And that's going to be restraint of trade. There'll be restraint of trade litigation going on there. And so that's bad. Litigation is never good. And so I really can't help that person. That's somebody stuck in the old days.
Hmm.
That happen. So I don't think I can help those people. What I can help is when two people have a really genuine disagreement and they're both well-minded, they're both
Mhm.
speaking based on knowledge. And then what we have to do is educate them. You're concerned, for example, I'll give you one good example of that. I was meeting with a surgeon. I went to a great meeting down in Cabo with Frank Phillips invited me. What a great
Mhm.
surgeon. And I was discussing with one of the surgeons there. And he said, well, I'm just worried. He said, you can do this procedure, Tim. I can't remember what procedure we were talking about. Doug Bill can do it, but most of the pain guys shouldn't do it because they can't treat their own complication. And I
Mm.
said, that may be the worst thing I've ever heard because I heard the heart surgeon say the same thing when I was a med student about stents, right? And guess what happened?
Right.
That didn't really matter. But I also told the surgeon if he does a fusion and it gets an infection, he doesn't treat the infection, infectious disease treats it, right? If he does a surgery and there's a nerve injury and it needs a stimulator, most ortho spine surgeons won't put the device in. We will.
Mm.
So no one in our space really treats all their own complications. We have to collaborate there
Right.
as well. So if I have an
Mhm.
epidural hematoma, which knock on wood, I've never had one in 32 years, then I know my surgeon's gonna drain the epidural hematoma. I'm not too worried about that because that's the ethical thing he or she would need to do. And the same thing here, we're gonna treat any complications. So I do think
Yeah.
people that make arguments like that, I'm hopeful we can educate them and that we can solve that skeptical problem, and we may not be able to. And again, those people are gonna lose because 'cause they're gonna be on an island by themselves eventually because other people are gonna move on.
Yeah. So, what types of guardrails do you think should be in place, or do you currently have in place for how you evaluate should I do this procedure or not? Is it simply a matter of how large the patient's specific defect is? And, if it's grade two, unstable, okay, great. I'm not going to treat that. But what type of guardrails do you think should be there?
No, I love that question. So I think there's a lot of things there, you know. So some people do have diseases that I just can't treat, and I know that. But then the question is, does everyone have good judgment there? And they don't, right? So there are going to be some people make mistakes. Two is there's going to be surgeons who operate on people they probably shouldn't, and that a
Right.
colleague would have been more conservative. If in my region, I know if I want someone to have a surgery, who to send them to, and if I want someone to say
Hmm.
they're probably not a candidate, who to send them to. And they're both
Hmm.
good guys and good doctors, but they have different mentalities.
Hmm.
No, I think some of the guardrails are credentialing. So you have to go through a credentialing process in most facilities. You have to be hands-on trained. A new procedure comes out, you're going to go get the industry training. You're going to have the mentoring. What's missing is
Hmm.
the post-mentoring. That's why we're doing the certification program. I think the other thing that worries me though, if you own your own facility, then you might be credentialing yourself. And that does worry me a
Right.
great deal. I think that sometimes, and again, there's a lot of great ambulatory surgery centers out there, but there are some ASCs where the credentialing is pretty weak. And so I think that
Mhm.
might be our biggest risk for all of us right now is that weakness of ASC credentialing, because be meticulous as a Joint Commission accredited hospital would be, for example, the
Right.
credentialing committee.
Right.
The other guardrail is each other, you know, and I think when someone asks me about a procedure, I'm gonna tell them, "You shouldn't be doing this," and I do a lot of malpractice defense work, and the first thing I
Yeah.
look at, were they within their scope of practice when they did something? And if they haven't been trained well for what they were doing, I can't defend the case.
Right.
So
Yeah.
so I think we have to police ourselves some as well. And I think lastly, I think we have to have mentoring where a older person says to a younger person, if you want to do the same thing I'm doing, here's what you need
Mhm.
to do to be able to do it safely and efficiently
Right.
and with
Right.
good efficacy. And I think if we don't do that, we're going to get into trouble as well. So that's a
Yeah.
long answer, but I think that
Yeah.
the guardrail to me is it should be credentialing, but it doesn't always work that way. And credentialing, it's got to be self-policing. If that doesn't work, it's got to be a mentoring. And some people we can't help, and those people may need to again at some point lose their ability to do those procedures, and that would be
Right.
insurance based probably.
Mhm. Mhm. Yeah, no, I think I mean, I love that I love the idea of these apprenticeship type approaches because the younger generation should always be looking to the generation before them and learning from them. What did you do well? What did you not do well? How can we learn from those mistakes and ultimately continue to improve? There has to be that generational download of information so that we can make that we can make it better. we can take that algorithm that you've developed over the last 30 years and then apply it to the next 30 years and the next 30 years, right? There has to be that passing down of knowledge. It's really, I love the way you laid that out. So, you know, taking that concept of what you built 30 years, next 30 years following there, let's talk about a little bit about the future vision, which we all know that will change. But what do you think in the next 5 years, how a patient's journey might change? And what are you predicting with the advent of more AI and big data plays? Are you starting to use any of that within your practice? Help me understand your thoughts around that.
Well, ideally, we get America healthier and people would be skinnier and they would be in better shape and they'd eat healthier and they'd have good
Yeah.
DNA. And, well, that ain't going to happen, I don't think. So barring that,
Just a select few will.
yeah, and I encourage that in all my patients, to exercise more, eat healthy, but I'm not real successful with that for the most part. I do think that AI is really important. It's so important that our society created an AI division, not a committee, but a division, which will be involved in several projects and we'll do some collaboration with industry on those projects to develop new ways to do things.
Okay.
We're doing that for things like pre-certification, because insurance companies are using that to inappropriately deny things
Mm,
to help us make sure we get appropriate things approved. And AI is going to be involved in product development. I think phase one, we're going to see more and more use of AI to improve on current products that are available. So we talked about all these MIS things coming along. They're going to get
mm,
more streamlined. A good example, we do something called Minuteman. G6 is coming out.
yeah.
It's going to be so small compared to G1. It's amazing the difference in size. So that's going to be, then that all goes back to AI engineering and 3D example.
Yeah.
So we're going to see more of that. We're going to see more analytics with AI and big data combined. And right now, I
Mm,
was just talking to a young man recently. We're really going to can we look at big data and look at everyone that had these 10 procedures and
mm,
predict who should have had what based on who failed and who succeeded based on big data. So
mm,
eventually, I think in the next 5 years, you may walk into my office. We may put your MRI into our AI system with your X-rays and your history, and my system may spit out, this person with their best option right now is BVN, basal vertebral nerve stimulation. It may spit out, you should go right to neuromodulation. Think about a stimulator. It may spit out, should consider a two-level, decompressive fusion by your surgeon. I think we're going to know that based on the analytics of big data. Now, does that mean that that should be what we do? No, but it'll give you a hint of probably the most likely successful outcome. But then you'll look at the patient and say, well, AI missed this because there's something on immunosuppressants, and they probably won't do well with incisions, and they've had a kidney transplant. AI may miss those things initially because it has to learn with you, right? So
right.
that's another big change. We're gonna use AI to have analytics to predict which procedure has the best chance of success going forward in a very individualized fashion, almost like having a 23andMe DNA test. It's gonna be very, very
Yeah.
similar.
Oh, that's exciting. I mean, we see how it works in other industries. So there's no doubt that it's going to come. No doubt. Now on the economic front, do you think that these changes are going to end up saving us money, costing more? How is that going to affect reimbursement? That's those are big questions.
Yeah, so that's the question that gives everyone heartburn, I think, right? That apparently there was a recent meeting of IPSIS, which I'm not a part of IPSIS, but someone came back from that meeting and said it was a good meeting, but it was very, very depressing because of the talks about denials and all that.
Yeah. Yeah.
Uh, I will say that to me, if I'm a spine surgeon right now, I'm very nervous because if the
Mm,
new reimbursement methods go into place, where you have this diagnosis and there's this bucket of money to take care of you, and this procedure is $50,000 or more, and this procedure is 10, and you get this procedure done, you won't get any more care probably because you're gonna run out your bucket of money. Most people won't want a big procedure, early
mhm.
on, sure. So I'd be
Yeah.
very nervous if I offer a procedure that's very, very big and expensive. It requires inpatient stay because it's gonna be very unpopular in those bucketed of money type procedures. So that's number 2. I think reimbursement is gonna be a struggle. Insurance companies get more profitable every year. Hate to be a skeptic, but they get more profitable every year. Their CEOs are making 50 or 60 million a year, and I can't get someone approved for a procedure that they meet every criteria for FDA, CMS, and Medicare. And I have a managed
Yeah.
Medicare program that won't approve them for some reason that's totally
Right.
crazy, or they'll say it's
Right.
experimental, although there's a CPT code, which means it's no longer experimental. So I do think that we have this terrible battle with physicians and patients against most insurers, and that changes, and maybe big data will help with that. But I think that we do have some really not genuine people that really are more concerned with profit than they are the patient. And that does a
Yeah.
lot. So I don't know if we can overcome that with AI or big data or anything we
Right.
do. I think one way we can do is keep getting more and more data as we go, keep doing more stuff, do more research, and overwhelm them with data that really is so supportive that it's hard to deny someone.
Yeah. 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 It's a challenge and something that, I mean, I know I mentioned to you, my dad was in PM&R for many, many years and finally changed his entire practice due to reimbursement rates changing. He
Absolutely.
said,
Absolutely.
I have to approach this differently." So it's certainly a massive problem that's been happening for, just year after year after year.
I think
So
it contributes to burnout as well. I have a lot of older
yeah.
doctors who tell me, well, older, they're my age, but I'm older now, but they'll say, I'm going to quit practicing. I just can't take it anymore. I'm so burnt out. I hate my life, blah, blah, blah. They'll look at
Yeah.
me and say, are you going to quit too? And I'm like, heck no, I'm going to go another 10 or 20 years. If I'm healthy, I'm not burnt out at all
Yeah.
because I know we have to keep fighting the good
Mm.
to help patients. So I'm actually the opposite of burnout right now, TJ. I feel like I want to
Yeah.
go harder than I've ever gone.
I love that. How have you managed that though? Right? So you have the big vision, but this is such an important topic. What have you done to structure your life in a way that helps you avoid that?
Yeah, so I think, people that work all the time and they focus on money first and that's all they focus, end up burnout. Okay. So I think that's
Mhm.
one. Two is I think I've always had philosophy. I'll tell you, I have two real secrets to me, TJ. I could be wrong. This is
Okay.
for me.
Okay.
So philosophy number one is you have to have priority. So for me, it's always God first, and again, someone's not religious, that's up to them. Whatever their priority is fine with me. But
Yeah.
God first, family second, and medicine third. But family, I always tell young physicians, part of that family part is exercise and diet. If you're not healthy, you'll die and you won't see your family. So I think
Right.
because and then the part 2 is having a good time management strategy. So I wake
Mm.
up at 5 AM, I'm either in the pool on the bike or running by 5:30. Every day,
Mhm.
I've got a very structured schedule, and then at the end of the day, I've got another workout. And then the last thing, in that whole equation is I've got good social and family relationships where I have friends and family that I interact with often. That's very, very important to avoid burnout as well. So I think it's all
Yeah.
those things, time management, prioritization, social interaction, and exercise. And that's made me really feel more energized about what we're doing every day than I've ever felt.
Mhm. I love that. I love that. There's a lot of people that currently ask me that. What do I need to do? What do I need to do to structure my practice, my life, if they're a professional, if they're a doc? And I couldn't agree with you more. I mean, that's essentially the way that I've had to structure my life too.
Great.
God, family, work. Everything else is secondary, right? You have to follow that order of priorities. And if you don't, you start to feel burnt out. You just can't do it. You
Absolutely.
can't.
And there's people who work every Saturday. I know young doctors who work every Saturday. They make a lot of money that way, right? They make a lot of
Right.
money. And
Mhm.
that would suck for me. I like to, travel, exercise, hang out with
Yeah.
my kids, family, see the grandbaby, you know, that's the other
Yeah.
thing you have to ask yourself, how much do you really need to make to be happy, you know?
Yeah. That's always the question, right? If it's just money, then that's hard to maintain for a long time. Um,
Right.
so
Absolutely.
you- what's the next race that you have coming up? I know you're a huge triathlete.
So I had rhabdo twice the last 18 months. I had a full thickness tear in my hamstring and my third bad water event, and on Mount Whitney, I went to rhabdo, and so that was not good. And then I went to rhabdo in Miami after the Keys 50 miler and the heat down there last summer, and then I ended up flown to the ICU, my first helicopter ride. Um, so I had to prove myself to my wife and children that I could do it without dying. So I've been building back up, did a couple 50 milers, I did Boston again, I did my 20th Boston, did a couple triathlons. So this
Yeah.
next my next year of racing, I've got the Javelina 100 in Arizona coming up in about
Okay.
5. So I've been training for that. And then I've got the New York City Marathon 6 days later. So we'll see if I can do that turnaround. It's gonna be
That's
tough.
brutal. Yeah.
The
Yeah.
Dallas Marathon with 5 for people that've never done a marathon before, so I'm gonna try to get those guys across the finish line and meet them for a beer at the end of that, and then I go into next year with it with, the Badwater Cape Fear 50 miler, and then I have, the Boston Marathon. I have my last Ironman Kona, it'll be my 10th and final trip to World Championship in Kona. I'm gonna retire from long distance triathlon next year after that, and then I hope to go back to Badwater again. We'll see how that goes.
Awesome. Awesome. Why did you get into it? What was the mental, you know, I know many people who have gotten into it and they just get addicted to it. They love it. They love the challenge. Is it the challenge? Is it what is it about it that
You
drives you to keep competing?
It may be mental illness, and some people think that, but, my friends do the same thing I do, so I don't think it is because people around me do the same shit, so that I do, so, I think these are the first things, so you wanna accomplish. I started with half marathons, and I got pretty good at those, and they get boring, and then I did the marathon, and I got qualified for Boston. I broke 3 hours in Boston, and I was, "Okay, so pretty good at that." I couldn't
Yeah.
swim or bike, so I signed up for triathlon. I got pretty good at that, went to Kona a few times more. I got bored with that, and then I said, "What's the hardest 100 miler?" I went to Leadville, altitude, did that 4 times, and then what's the hardest to get into? Badwater is the hardest race to get into. Got to
Yeah.
Badwater, and now, it's really a matter of after this next season, getting through my last Kona, my last Badwater, what is there out there to do that you could put further, and then you aging at the same time, and I think I'm gonna try to keep fighting the battle with age here and keep going, so I don't know what the next challenge will be. I've been told by
Yeah.
my mountain climber friends I can't climb mountains because I will get killed because I don't quit until I'm on the verge of death. So I thought about Everest. I was just in the Andes Mountains last week, and I did some hiking up in the Andes, and I can see myself climbing, but on the other hand, I can see myself not being smart enough to stay safe climbing. So I don't know what's going to happen after next
We need
year.
you here.
Next
Yeah.
year is going to be an epic year, I hope, and hopefully I'll stay out of the
Yeah.
ICU to go.
Good. We hope that too. We need you around for a long time. So wrapping up here, I mean, again, thank you so much for joining us today, Dr. Deere. And I want to end it with one question. If there's one specific challenge or question you want to leave to the orthopedic surgeon community that are listening to this, what would that be?
No, I think the challenge is to, if you have interventional spine physicians around you who are well trained and
Hmm.
people that are approachable, I think you get together and you have break some bread, have some dinner, and talk about what the philosophies you both have are, and if they're way apart, there's got to be some common ground somewhere along the way there. And you really, I think if you're an older surgeon, you help mentor the interventional pain person to be better. If you're a younger surgeon, maybe you learn some things from the older pain physician. If you're both young, I think you can really then collaborate long term. I've seen some of the best relationships where the surgeon and the interventional pain specialist collaborate for years. And I've had that experience myself, where, I've really learned a lot from the surgeon. And then the great thing when you have that relationship, you get on the phone and you say, "Hey, Johnny, I've got a patient who has this
Right.
problem. Can you see him next week?" And they go, "Sure, I'll get him in tomorrow," and vice versa. So I think that having dinner with the people and really discussing in a very open and level-headed, objective way without getting emotional what you're both doing, what you both feels appropriate, and then you have to be open-minded then because you may be disagreed with, and then you have to come to some common ground for patients. So that would be how I leave it, and the other thing I would leave it with, anyone wants to talk to me about Aspen or wants to come and really see what it's all about next July in South Beach at Fountain Blue Hotel, come join us. We have a lot of surgeons there, and, we certainly like to get more surgeons involved, and then, many of those surgeons end up on the podium with us, over time. We have a lot of panels, and so and come and debate us. And we actually we every year we some of our panels are debates about who should do what. And
Oh, I
you
love
know,
that.
Dr. Khalil and some of those
Yeah.
people, Dr. Nunley and others have been really fantastic. And we don't have to agree on everything. We can disagree, and that's fine. We just want to disagree in a very professional, objective, non-personal manner. That's what I hate about LinkedIn sometimes when people fight, and
Yep.
I think we want to do it in an open format that's very constructive.
Mhm. Well, we certainly endorse that statement, and we recommend everyone go check out Aspen. I know I'm planning to be there next year.
Great.
Can't wait to go. I mean, it's an incredible event. So again, Dr. Deere, thank you so much for spending time with us today. Really excited to get this out into the market and encourage some healthy debate so that we can
Absolutely.
ultimately continue to improve patient care. That's the
100.
goal.
Absolutely.
Awesome.
Thank you
Well,
for
thank
having
you
me.
again.
And to everyone out there, certainly hope to meet many of you down the road.
Absolutely. All right. Thanks again.